Welcome to this session of the Innovative Conversations. These conversations are sponsored by the Center of Excellence for Child and Adolescent Behavioral Health, located at the Begun Center at Case Western Reserve University. The podcasts are also supported by funding from the Ohio Department of Mental Health and Addiction Services and a federal grant. So we've been doing these podcasts for several years now, choosing topical issues of relevance to the child and adolescent and family behavioral health area. And today we are going to talk about intensive home-based treatment. We are going to refer to it as IHBT, even though in Ohio, that is an umbrella term that encompasses other known interventions that come under that umbrella of in-home. So that would be functional family therapy, multisystemic therapy, integrated co-current treatment. I'm not as sure if IFAST is in there as yet, but I think that's possible. So there are a number of configurations, if you will, of home-based and intensive home-based services. And our rules in Ohio encompass multiple ones. And I think you'll hear that from our guests today. So having said that, I would like for each of our guests to introduce themselves briefly, the organization that they're with, and their role in relation to IHBT. An impressive group of people, and you will see their bio sketches posted here with the podcast. So, Georgeanne, maybe we could start with you.
Yeah. Hi, my name is Georgeanne Voros. I am the Chief Clinical Officer at Child and Adolescent Behavioral Health in Stark County, Ohio.
Great. Welcome. Carl?
Hi, Patrick. Thank you for having me here today. It's a pleasure to be here with you, Jeff, Georgeanne, and Heather. My name is Carl Brass. I'm the Executive Director of Belfair JCB. Belfair is headquartered, it's a nonprofit headquartered here in Shaker Heights, Ohio, within Cuyahoga County. And each year, Belfair provides services to about 25,000 youth and families here in Cuyahoga County, as well as Lorain, Medina, and Summit counties. And Belfair's been a long-time provider of IHBT services going back all the way to the 1980s.
Right, great. And Heather?
Good morning. My name is Heather Craver. I am the Chief Clinical Officer at Cadence Care Network, and we provide both MST in 5 counties as well as our IHBT program in 6.
Welcome. And Jeff?
Good morning, Patrick, and thank you for including me in the podcast. My name is Jeff Spears, and I am currently with the Child and Adolescent Behavioral Health Center of Excellence at Case Western Reserve, and I am a project lead for the development through grants to work with community providers to develop intensive home-based treatment programs and also some multi-systemic therapy programs and FFT programs.
Mm-hmm. So you know all of these folks and they know you, right?
Absolutely. Well, I've been around a while. I was 30 with the juvenile justice system in Ohio, state agency, where I worked for almost 20 years in the development of behavioral health services for kids in the JJ system.
Yeah, great. I'm glad to have all of you. I can't think of a better group of folks to have this discussion with. Let me just say briefly that what we would like our listeners to take away from this conversation is a greater sense of what it takes to implement a model program like IHBT, whichever particular iteration you're doing. And equally important is the sustainability, because I think we have learned over time that both of those buckets have very distinct features that contribute to their success and can contribute to their challenges. And so, that's kind of what we'd like to take away. This is not to be a podcast about the clinical aspects per se of IHBT, but rather, like I said, the implementation and the sustainability. So Jeff's going to set the table for us and read just a very short definition and purpose of IHBT, just so we're all kind of gathered around those words.
Thank you, Patrick.
Mhm.
You know, IHBT is an intensive, time-limited mental health service for youth with serious emotional disabilities and their families. The services are provided in the home, the school, and the community where youth live, with the goal of safely maintaining the youth in a least restrictive environment and the most normative environment. An individual clinician or a team of providers under IHBT deliver a comprehensive set of clinical and rehabilitative services that are designed to treat presenting mental health conditions and significantly impaired functioning. Uh, the main purpose of IHBT is really to reduce the need for more restrictive out-of-home treatment, like a psychiatric hospitalization or a psychiatric residential treatment facility or other residential treatment program. Another purpose of IHBT services is the reunification from more restrictive placements. So working with the kiddo to get them back home with their family. It's also has a main purpose of mental health stabilization and promoting safety.
Thanks, Jeff. So that says a lot in not so many words, actually. It really encompasses probably over 25 years worth of work in Ohio to get where we are today. I believe when you see this podcast, you will be able to check out some of the developmental pictures of how IHBT has rolled out over the last couple of years, particularly from its startings in a few counties to, I think, Jeff shared with me earlier that we only have 10 counties that do not have access to some form of IHBT, which is, I think, a remarkable success we can all be proud of here in our state. So,
Absolutely, Patrick. I just
yeah.
want to add, in March of 2024, we only had 39 counties of the 88 in Ohio with the service. And now we have in 78 counties of the state. So there's only 10 counties left in the state without an IHBT service. And this is very exciting. And it's quite an accomplishment, given that these are very intensive services. And I just kind of wanted to add, a caseload for those providing services for kids are really limited to about 4 to 6 youth and families.
Mhm.
And these services are very, very intensive with multiple sessions throughout the week. And there'll be these clinicians and teams are out there meeting with these families 4 to 6 hours per week.
Yeah. 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 I think it's an approach that, as we worked with it over the years, have found great success. And but accompanying that also are a lot of tools that are needed to get it in place and to keep it in place. So what I'd like to turn to our provider experts. Um, Tell me, whoever wants to start off, tell me kind of what motivated your particular agency or organization to look at the model of IHBT and say, this is something that I think should be part of our portfolio. Just some of the dynamics that took place. So, Heather, I see you nodding, so I actually
Sure.
am going to call on you.
Yeah, I can start. So, for Cadence Care, we actually went back. We used to have an evidence-based program we ran out of our treatment foster care department. And we saw some of the successes, some of the challenges with that program. And a lot of our juvenile courts had approached us. We saw a trend of youth, at high risk for being removed from their homes, involved with probation, diversion, and it just seemed like a natural fit. So we first wrote for the Behavioral Health Juvenile Justice Grant, I think 13 years ago, launched our first MST program, 12 years ago. We've had it, and it just kind of went from there. We began with, I think, 3 counties in Northeast Ohio, and then added on 2 additional counties very quickly, and had 2 teams. So we've seen the success of MST, keeping kids at home, helping them stay in school, stay out of further legal trouble. And we've seen a gap for several years with that age 7 to 12 range. And we've had several of our community partners expressing the same. There's a gap. There's nothing really intensive for this age. So launching our IHBT program really made sense.
Great. It's a great story. In fact, I do believe I was at your kickoff meeting for launching MST with a community group. I remember that quite fondly, and I remember the donuts that we had afterwards. So either Georgine or Carl, what about Belfair and child and adolescent? How did you jump into this?
So CNA, I'm sorry. Do you want to go, Carl?
No, please, Georgine, you.
CNA came about serving MST about 7 years ago in 2018. MST had long been in Stark County and with another agency. In 2018, the agency closed and we took over the MST program. So it's been a lot of ups and downs. We have had, oh gosh, at one time, I think we had 9 MST therapists. We had 2 standard teams and 1 PSB team. COVID changed everything. We lost a lot of our therapists. We were about a year and a half ago down to 1 therapist, 1 supervisor. With Jeff's help and the grant that we got, we now have 5 therapists and 1 supervisor. So it's made a big difference. We were in 3 counties when we first took it over. Now we're currently in 2, Stark and Medina counties. And we have a wonderful supervisor, someone who we knew who had worked here previously that left for another agency. We got her back, and she is a huge part of making that team successful. So MST was a great fit for CNA since the only thing we do is kids and adolescents and families. So it made a lot of sense for us to take it over. It's been wonderful. I love the program. I see the progress that families make. I couldn't be happier with it. When we get into funding streams, we can talk about that. That's something I could be happier with. But the program in and of itself, we love, and our funders, the court loves, the communities love, the families find extremely helpful. So
and
it's a great program.
We'll certainly touch base on the funding when we talk about the sustainability. I think that's just so key. I think it's one of the long lessons we've learned as we step back over all these years is how we need to pay as much attention to the long-term future of a program, not only to its startup. which is often where the energy goes. Um, and without all those other wheels, like you said, it can get a little rocky, it can get a little shaky. So, and Carl, what about Belfair? What's your history?
So Belfair's history broadly goes back more than 150 years, and Belfair started as an orphanage
Mm-hmm.
for Jewish soldiers from the north all the way after the Civil War. Don't worry, I'm not going to give you a play-by-play of everything that's happened since then till now. But my point here is, or what I'm getting to is that the Belfair's arc really mirrors the arc for what services for children have looked like through the decades. And
Mm-hmm.
what Belfair, I believe, has done through that entire arc is both been a leader in clinical technology, but has also sort of followed where the clinical technology goes. And so
Mm-hmm.
going all the way back to the 1980s, as more and more it was understood that serving children and families should happen in the community whenever possible, as opposed to on a campus or within residential settings. Belfair was looking for the best models and the best therapeutic models for care to help these youth and families in the community. And so going all the way back to the 1980s, IHBT was something that Belfair was
Mm-hmm.
heavily involved in.
Mm-hmm.
And as the sort of timeline advances for IHBT, Belfair's sort of there every step of the way. So getting into the early 2000s as a recognized community need sort of imposed upon the challenges that any given youth or family faced, facing as substance abuse is recognized to be a larger and
Mm-hmm.
larger issue. Belfair moves in the early 2000s into integrated co-occurring treatment in concert with its intensive home-based model. As we move forward further, Belfair adopts functional family therapy models and was actually there side by side with the Center of Excellence and the Center for Innovative Practices as we went to the state to try and raise awareness of the importance of this service, and ultimately, again, a credit to Center of Excellence and Innovative Practices, ultimately get it recognized as a funded service within the state of Ohio through Medicaid.
Mm-hmm.
So that's sort of our history
Mm-hmm.
with IHBT. And today we have, as I think I said at the outset, we have just to use the acronyms, we have ICT, we have FFT, we have IFAST, we have all the different models. We have different teams located, 5 different teams located across 4 counties.
Great, great. Well, I'm old enough, and I know you all are not, but I am old enough to remember when the discussions regarding substance abuse treatment and mental health treatment were miles and miles apart. They were really thought of as, incredibly distinctive. If you all might remember, there used to be 2 departments, one of drug and alcohol and one for mental health. And I think, ICT, I think is our attempt to indicate, and I think folks have pretty much embraced it, that those issues cannot be unraveled in 2 separate venues, that you really need an integrated approach. So appreciate that you all have been a leader in implementing that particular service as well. So yeah, that's great. That's great. Jeff, to set the table just a little bit again, before we get into some of the implementation and sustainability, can you give us kind of a quick overview of some of the funding opportunities and strategies that have occurred over the last couple of years, particularly, that have helped kind of move these maps, if you will, to, a greater and greater number of sites?
Thank you, Patrick. Yes, there's been 2 funding opportunities that really, I thought, helped move the needle. The first was through the State Department of Job and Family Services in response to kind of their plan to implement the Federal Family First Prevention Services Act. Um, Under that initiative, um, the state agency, with the assistance of the Center of Excellence, provided funding that was then through grant programs distributed to providers to develop additional functional family therapy teams and multi-systemic therapy teams. Then on top of that, and more recently, was a very, very generous investment made by the Ohio Department of Medicaid of $10 million to support the development of IHBT services across Ohio. With the $10 million initiative, there were 24 community behavioral health providers, and we have 3 of them here today, that were selected, and they have worked with the Child and Adolescent Behavioral Health Center of Excellence at Case Western, and launched to expand critical mental health services, actually in 59 counties. So under this grant program, so there was, in some of those 59 counties, there was some existing services, and then it was an additional service to meet needs. And then in some counties, it was the first time they'd ever had a service. So that's just fantastic. And as I said earlier, Ohio's down to 10 counties out of 88 without an intensive home-based treatment service. Also, with the money from the Department of Medicaid, those community behavioral health providers that had some intensive home-based services that were not grant recipients also received additional funding to help support kind of some incentives, so they could keep their staff and hopefully attract more staff.
Okay, great, thanks. Yeah, I mean, it's like, we used to use the term braided funding. I don't know if we still use that typically, but the idea that a single funding stream was never going to cut it in terms of supporting these services. And so how did we access other levels of support that would allow us to do this work? And so I think we started out very locally in some cases where different systems made it, collaborative investment going forward. Other folks wrote grants. Other folks have been able to take advantage of the progress we've made with Medicaid. So yeah, it's not a one-size-fits-all formula, although we have gotten close to that with the case rate approach, but we can talk about that a little bit later in your experiences with that. I'd like to ask each of you about, you are now, quite honestly, I think hold really kind of historically important roles in terms of experience. And we have so many new providers coming on board that I think and hope that this will be helpful to them. I shouldn't say I hope, I know it will be. But talk a little bit about your implementation processes, and you can include, what some of the rough edges were, or what were some of the issues that really, if you stepped back over time and said, whoa, if we had only known. I mean, that to me is kind of how I've approached things. Like, had I known that 5 years ago, I might have done something different. But maybe talk a little bit about that implementation phase. So we'll make the assumption you've selected a service, you've gotten some support, you're moving forward, and here it goes. You've got the funding. What were some of the steps you needed to take, and some of the journeys that took you on?
I'm happy to just jump in, Patrick, here and say, in terms of implementation, there was sort of everything that happened before 24 months ago, for Belfair's experience, and then there's everything that's happened really over the last year and change. Implementation in the past was sufficiently difficult because this work is incredibly challenging. Jeff spoke in his definition to some of the reasons why that's the case. These therapy jobs are unlike jobs that other psychotherapists are asked to take on. It's not just the intensity in terms of the frequency with which you might be meeting with a family. It's going into those neighborhoods. It's going into those homes. It's having that degree of proximity to youth and families that are really struggling in the most dire ways. And that is not a challenge that I think every therapist who has a counseling or social work or psychology degree is equipped to do. So it was always hard to find people that were going to be willing to do this. And in order to find people that were willing to do this and then would stay, required leadership, clinical leadership, people that understood the work, that were savvy enough in terms of their clinical training and also savvy enough in terms of their supervision to be able to support these therapists that were going to do this difficult work. So all of that is just incredibly difficult. Before and prior till just a couple of years ago, prior to some of the money that's incredibly been put into the system through ODM and through DGFS, as Jeff said, you had to do this at Belfair as a nonprofit, you had to do this on reimbursement that looked almost indistinguishable from the same resources that were provided to agencies like Belfair for more traditional office-based counseling. And so you were going to take, you couldn't, there wasn't funds sufficient to really woo therapists to come and do this difficult work from the outset. It was difficult once they went in to maintain it. And I would say that Belfair was able to do it through the years because we were fortunate enough to have really dedicated clinical leaders and people in clinical leadership positions over our intensive home-based therapy teams that were dedicated to the work and against, all the challenges stayed because they understood how important the work was. And that allowed Belfair to maintain a team through all of these decades, though we did it through almost all that time at a loss, at a financial loss. It was a mission-driven service line. And unfortunately, as Georgeanne was referencing, as during pandemic and as all of these things it just became more and more challenging to provide community-based services, our team got incredibly small, and it wasn't clear how we were going to be able to provide this vital service that we think helps families stay together, helps kids avoid major unwanted outcomes, psychiatric hospitalizations, displacement from family, or God forbid, worse than that. How are we ever going to grow this thing back? And implementation now with sufficient resources looks like we have the ability to offer these therapists differentiated salaries, which is deserved, which allows us to then recruit therapists who otherwise, all things being equal, might be doing something else. And the $10 million that has been put into the system through ODM allowed us to take innovative approaches towards talent acquisition, working with talent agencies to offer hiring bonuses, retention bonuses. And so in terms of implementation, I'd say the challenge is always going to be to find the right clinical leaders and then to find the right people to take it. In terms of how that has looked for Belfair, it looked incredibly difficult for a very long time. It's still difficult, but has been made much more manageable. And we've seen our team grow by threefold really in the last 12 months, which is remarkable. So sorry to drone on for so long, but that's
no. I think that's great. I think your line, if you will, of previous to the last 24 months, the environment, at least financially, was very, very different, and now looks very, very different, and in a good way. So, Georgeanne, what about CNA? How'd you all go about with implementation and feeling that you were on the right path to get it where it needed to be?
First of all, I think I agree with everything that Carl said. It's been incredibly difficult prior to the last year and a half. What we have found to be most successful is finding the right people. And for a long time, we wondered if they were out there because we weren't finding them. They the right people they know their value. And if we can
Mhm.
pay them and support them in a way that's reasonable, they come. They're
Mhm.
there. We find them. We had them before they left, due to pandemic and salaries and all kinds of things, but we found more of them. And what we found, in fact, we've even kind of taken this thought over to other areas of our agency. We were having difficulty with diagnostic assessors. And, we looked at what we had done with MST to be successful, and we extrapolated those systems that worked and have found it to be successful in recruiting for other areas too. It's basically just setting up the job in the right way with the right support, with the right reimbursement, and the people come. We were as shocked as anybody that we actually got 6 therapists.
Mhm.
One of them had to leave because of health reasons.
Mhm.
She's actually hoping to come back at some point.
Right.
But yeah, we found that if you build it right and manage it right, that there are people who love to do this, who are kind of built to do this, and they'll
Yes.
come and do it if we do it right.
Yeah. Yeah. Great example. Great. I think that paints a really great picture. What about at Cadence? Heather?
I could not agree more with everything said. We also operated at a loss for our MST program prior to the case rate. Thank goodness for the grant funding that we did receive to supplement. It is about the right people. And even though we traditionally have provided the majority of our treatment services in home, in school, in the community, it's still some of our clinicians who may do very well with your more traditional outpatient
Mhm.
clients were not good fits for intensive home base. And we've found that it's not only that initial
Yeah.
training, it's that ongoing training of staff, the boosters, the one-on-one skill building sessions, just that really make them successful. And like was also stated, just that leadership. We have phenomenal MST and IHBT supervisors, and they get the models, and they get what fidelity means and all of the inherent challenges. So they can also rely on each other
Mhm.
to, as they see successes on their teams and challenges, they can share, and they
Yeah.
do.
Yeah. So each of you kind of talked a little bit about the finance and the people, which is um, two obvious, really important cornerstones. What other tools, and you began to talk about this a little bit, Heather, with the coaching and the consulting. What about the other tools that come along with IHBT that you think maybe sets it apart from, um, a more traditional approach, shall we say? And I'm not making a judgment there. I'm just saying, there are traditional approaches, and there's a place for those in our system of care, absolutely. But say a little bit more maybe about the coaching and the support to fidelity, and how you manage that.
Yeah, absolutely. So looking, for example, at the frequency of sessions, the
Hmm.
amount of sessions each week, showing our clinicians the data and showing them, look, this is where you need to be, and maybe, you fell a little bit behind this month. How do we get you working with your families more? How are you going out when you have a session? Oh, we see the report says your sessions are averaging an hour. Well, let's look at the interventions you're providing. Let's
Mhm.
this toolkit with additional interventions and going through specifically with, what that child's needs are. And so you can spend more time working with, family and child and lengthen your sessions. Things such as making sure there's regular communication. With our IHBT program, we implemented the Teams model.
Mhm.
So making sure there's that regular communication between the therapist and the case manager is, also being driven by the supervisor. We utilize our tools from MST a lot with our IHBT program. We set up our supervision structure to just really mirror it.
Mhm.
We really felt if it's not broken, why fix it and why
Yeah.
recreate the wheel?
Yeah. Yeah, I think each of the models have um, unique strengths. And I think the idea of being able to, look across the room and say, I kind of like some of the outcomes that those folks are getting, or some of the approaches, or some of the retention, or some, and yeah, I mean, that's how we learn and progress. Carl or Jean, you have any other thoughts about implementation tools that feel particularly important?
For MST, I think the experts make all the difference. We can take a bachelor's level LSW, and because of the support that we have from the experts, teach them everything that they need to know, and they're quite good at what they do. They're
Mhm. Mhm.
even the master's level people that we have, we take some early career therapists,
Mhm.
and what they love the most about MST sometimes is the support that they get and the training that they get. I've heard many times that we can take these skills and, we feel like we can learn anything now and move into any other facet of this field. And, they have a confidence, they feel like they've done kind of the toughest
Mhm. Mhm.
work. So then they feel more confident that they can learn and do anything that they want to. It's a great, I love the MST model. It's a great model with great support, and it gets great outcomes.
Mhm. Cool.
I don't believe I have a lot of else to shed on the subject. I think Georgine and Heather did a very nice job. I do just want to, put a point on. I think the idea of utilizing evidence-based practices to provide meaningful outcomes is a term thrown around extremely loosely in the current environment. And just as Georgine and Heather said, what is fantastic in terms of implementation or a tool of implementation is having CASE and having the Center for Innovative Practices as direct partners and collaborators. I think it raises the level of expectation for the members of the team. It adds cachet, and again the just that ongoing collaboration, and then again looking to the clinical leadership. I think it provides a fidelity to an evidence-based practice that looks unlike a lot of
Yeah.
what you find anywhere else.
Yeah. Well, it's interesting because, and I'm sure you've heard this too, but, in some models, folks will say, well, I've been doing this for so long. Do I need to keep having these coaching sessions and these consultations? And I once had a boss who said, when you have somebody at the top of their game, that would be the last place you would take away the coach. Just because they were doing well at that moment, that's where you want to keep them, and that's where you want to improve. So that's not the time to say, oh, you've been doing this long enough, kind of you're on your own. So the idea that coaching is a really integral, and call it consulting, call it coaching, call it support, lots of different words. But I think that is one of those really key features is that, and the reliance of a therapist on that. And Carl, I think you said in your comments, it's a very challenging role. And to some degree, the more challenging, the more coaching, the more consulting. And it isn't about longevity of career. It's about, where you are in, in your work experience and being open to support and open to new ideas. So I think that's great. Great. Um, Jeff, I'm wondering, since we touched base a little bit about the funding shift over the last couple of years, can you talk a little bit about that historically and kind of where things are and how that has helped shape where we are right now, which is very different than 2 years ago?
Oh, very different. Thank you, Patrick. I started, it's 20 years ago with the Behavioral Health Juvenile Justice Initiative at the Ohio Department of Youth Services. And, it funded a lot of these types of on a more limited basis, but it impacted quite a few counties. At that time, the reimbursement rate for the service just was not adequate. And so the department provided some additional funding to kind of offset those expenses. And at times, it still was not enough money. And then we started to see some changes later, and it really dovetails well with this initiative. The Department of Medicaid made some rate changes, and then there was a decision to go with a case rate, a monthly case rate, through Medicaid and Aetna Better Health, and under the initiative Ohio Rise. And with that case rate, it's just made a huge difference to providers. It's right now for the IHBT services that are delivered with Fidelity and MST, it's $3,000 a month, per child. So if you have a caseload of 4 to 6 kids, you can actually generate income that makes this much more sustainable. And then what's so great about the grant initiative, because that's income you're generating from work. But then there's that whole piece in the front. And this is where this very generous contribution by the Ohio Department of Medicaid has made such a difference. It provided dollars for providers to kind of do some very intensive recruiting, some some significant onboarding and training, and those types of activities that are just so vital in the front end, but are not reimbursable. So, these dollars have just really helped kind of, it was that seed that was so needed to get everything started.
Yeah. Yeah, and I'm assuming, Carl, that is pretty much the line you were considering in your comments regarding how different things are now than they were even just a couple of years ago.
Exactly that, Patrick. Yes.
Yeah, yeah. So, in a perfect world, all of those things would remain or even get better in terms of support, flexibility, investment from the state, collaboration with your local partners and state partners. But what do you think about when you think about, okay, that's how things are now. We also know that things change. That was just a great example. They went from this to this relatively quickly. What are your thoughts about sustainability, the opportunities for it, as well as the vulnerabilities of it at this moment or at this juncture we're at?
I for one believe in terms of the sustainability. I think once Georgine made the comments earlier that sort of once you build a team and once you get people involved in this work, it's not going to be the case that that everyone has the stomach for it or that it's what everybody wants to do for the rest of their career. But I do believe that the people who come into this work see just how meaningful it is. Those that want to stay in it, they see how meaningful it is, and it becomes extremely difficult to imagine transitioning to something that is sort of less intensive and less meaningful. And people really, really can build and sustain teams for a great many years. And so I think what changes in funding and reimbursement has allowed us to do is really grow a program that I think will be self-sustaining for a good long while, so long as the bottom doesn't drop out. And that is for us, I think the primary vulnerability. The primary vulnerability is something changing, i.e., funding lost, funding changes, funding goes away, is I think really the only threat. What makes me feel optimistic is that I think the outcomes are so demonstrable, and that the value, so you can see the value so clearly, and that even for anybody that would be making decisions for more callous reasons around financing, you see the economic impact too, by providing this service to avoid much more expensive services like inpatient psychiatric hospitalization, like extended residential treatment stays. So even put the mission-driven reasons, the therapeutic value aside, I think it makes so much sense that's what makes me feel optimistic. But the vulnerability is just about the funding from my perspective.
Okay. Heather or Georgine, any thoughts about that?
I was going to say, in addition to the funding, I see two of the biggest opportunities and vulnerabilities being the same: staffing and referrals. So while we're fully staffed, you want to continue to grow your staff clinically and help them stay excited about the treatment, your supervisors the same way, and continue to grow their skill sets. Because if you lose staff, then you have a challenge there to rebuild. Referrals, keeping referrals coming, providing the quality treatment so your referral sources are happy with the work you're doing, and they see the value, and so they continue to refer more cases.
Okay. Yeah.
Patrick, I think that to me, what IHBT does is it strengthens families, and it strengthens our next generation. And any legislator or anybody who doesn't see the value in doing that is kind of beyond my comprehension. It's if a lot of the people who are in charge of the funding could shadow an MST worker for a week, I think it would completely change their perspective. It makes a huge difference. It reduces violence. It reduces out-of-home placements. It has so many positive results for communities and families. We know how to do it. We have people that can do it. We know that it works. It's kind of a no-brainer.
Yeah. So what I hear is that from your experience with implementation, that some of the things that even several years ago we would have been maybe more focused on have really become more a part of knowing how to do this, and like you just said, Georgie, knowing how to do it well, knowing what it takes and who it takes, and how it takes for it to be successful. And I think each of you talked a little bit about outcomes or results. Could you say a little bit more about that? And I don't necessarily mean data, but if you want to share data, that's fine. But just your thoughts around the outcomes that you're seeing in your respective programs.
Patrick, before we jump forward, I kind of throw something in about funding, because, I kind of see agencies kind of at a micro level, really into, really doing the work. And then I think taking a step back, coming from a state agency that, really had some years where our out-of-home placement costs were just eating up the budgets in places. And kind of looking at this and how did the state agency kind of deal with that by developing other types of resources and then investing the savings from reducing your out-of-home placement costs. And I think with IHBT and this significant build out that's happened with the assistance of the Department of Medicaid, we have an opportunity here. Ohio's Children's Services agencies in fiscal year 24, I was looking at the PCSAO fact book, Public Service Agency Association, and Ohio in fiscal year 24, spent 141 million in federal funding on out-of-home placements, and they spent 376 million local funding for over $500 million a year was spent on placing children out of home. And what I really would hope over time, we could take a look at kind of the different intersects within a community where maybe there's an opportunity to identify a kid earlier that's maybe on that trajectory of going to some type of out-of-home placement, be a hospital or a group home, a PRTF, and kind of then have some cost savings that way, because we know the outcomes are better through a service that works with the entire family in the home. And what I'm hoping over time is what we see is we kind of take opportunities to say, hey, we can reduce the out-of-home placement costs. And then I'm hoping that we could do a reinvestment to help service to the capacity that's really needed, because I recently surveyed the existing teams across the state, and there are still some considerable wait lists in some areas of the state for a service. And, hopefully a further build out of the home-based services could help reduce the wait list and then reduce these out-of-home placement costs that could be reinvested.
Yeah, I think that's a great point, Jeff. I think the reinvestment strategy is one that, this is just my opinion, folks, and I haven't been in state government for a long time, is not an area that I think we have fully explored or fully figured out actually how to do that reinvestment. And I think that's a great challenge for us to focus on over the next several years. Is how do we do this in a creative, supportive, fair, equitable kind of way? Because I think there are possibly ways in which to do that. So thanks, Jeff. I think that's a good point.
You're welcome, Patrick. Across all and really doing some intersystem coordination and collaboration. I think that's key here, because these placements are so necessary right now because there's just not an earlier service that's been identified to work with the youth and family. And I think we have a great opportunity with this.
I think so too. Yeah, I think so too. Kind of the next generation. So we were beginning to talk a little bit about outcomes and results. And so say whatever is comfortable for you as an organization in terms of what you've seen under that umbrella of results or outcomes. Whoever wants to start off there.
I'm happy. Again, I'm not going to get as you said, Patrick, I don't plan to get too far into the weeds of the data, but what Belfair can assert is that we've got decades at this point of outcomes data relevant to thousands of youth and families that we've served. And through our outcome studies, we establish baselines for problem severity, both for the youth and for the family, for overall functioning of the youth and the family, feelings of hopelessness. And over the course of decades, you can see in statistically significant ways through the provision of IHBT improvement on all of these measures. That is, what's the word I'm looking for? It's concretized over time. It's These are
Mhm.
large samples, and you can see the
Yeah.
impact. So we've got the hard data. We've also got data because of our partnerships with the juvenile courts.
Mhm.
You see an impact on recidivism rates, for children who have had an encounter with the court system. Belfair operates a continuum of services, so Belfair maintains still inpatient services today. So
Mhm.
it's not abstract for us to see the impact of kids coming out of inpatient care and what happens with those kids when they receive IHBT, i.e., these kids are far less likely to find their way back into
Right.
inpatient placement and out of home placement than kids that don't get those services.
Yeah. Good point. I like that. I like that. Heather,
Yeah,
thoughts?
sure. So with our MST program, we have consistently seen outcomes at or above the state average, the national average, keeping kids at home, in
Mhm.
school, without new legal charges. Our first cases opened in IHBT in August. So we're looking, not quite a year in,
Sure.
and we've already seen examples of reunification
Mhm.
successfully for families. Youth returning to school, in-person school, when prior to IHBT, they had done virtual learning because they couldn't
Right.
be maintained in person. We've seen youth really gain emotional regulation
Mm. Mhm.
skills and being able to identify those emotions. And then the secondary benefit of that is that decrease in aggression. And their caregivers or parents feeling more supported, feeling like they have the skills to help those youth when circumstances come
Yeah.
up.
Yeah.
So it's been a really neat thing to look
That's
at
great.
so far.
That's great. Georgine, anything you want to add to that in terms of
I think
results?
it's a program. MST is very data and measurement based. We get all kinds of, weekly, monthly,
Mhm.
quarterly, annually reports, as does our court and other community partners. They speak for themselves. The data is excellent
Mhm.
for MST, not just at our agency, but across the board. It's very well supported. Our our courts love MST. I think they were more thrilled than we were when we expanded, and we were happy. But they really recognize and tout the value of what IHBT does in this community.
Yeah. Yeah, I
Patrick,
think, I'm
if
sorry.
you'd also permit me, Patrick, just to
Sure.
jump in I have from one of our most recent surveys just a two-line testimonial from a parent I thought I could share that
Sure.
that maybe has more of an impact than speaking in broad terms on data. So this is a quote from a parent that said, Ms. Claudia, the therapist, has been invaluable to our family. She has made such a huge difference to us, coaching not only our boy, but his sisters and us, his parents.
Mm.
There is more harmony in our house, and we are forever grateful. And there's, as I'm sure there are for Georgine and Heather's teams, and as Jeff gets exposed, Jeff gets exposed to working with these teams, there's 100 of those firsthand accounts. But
Yeah.
I thought that it made sense to also hear from the family in that discussion.
Well,
It's so great to hear a family staying
oh, it
together.
is. Yeah.
Yeah.
And I think when I look back over the arc of all the years we've been doing this, it's really been great to be able to go from the power of that kind of testimonial and reflection to also add on to those stories the data, that shows, like you said, the reduction in out of home placement, the reduction in days in out of home, or, diversion from court, more days in school. I mean, those are, when we first started rolling out IHBT, MST, it always occurred to me, and I'm sure it's not an original thought, but the outcomes, kind of the universal outcomes of at home, in school, or at work, depending on, your situation. Positive family support. Um, I mean, those are outcomes that every single system that works with kids and families acknowledges. That's what we're here to do. So I think that while clinical, I'm putting quotes around that, outcomes are absolutely key in terms of, data collection and reflection. It's also those daily in the world outcomes that I think people also can respond to. Oh, you mean this is a kid who hadn't gone to school in 2 years and now is going to school? Oh, well, yeah, because we dealt with the anxiety, the depression, whatever. But that outcome, I think, really is powerful for people to hear that those changes can happen, and then that's what we're after, if you will. So, well, I know that we've probably gone over a little long, and I could go longer. I'm telling you, this has been a really great conversation. But let me just ask each of you if you have any wrap-up thoughts or any thoughts you might have to share with your colleagues who are maybe just at the beginning of some of the journey here of implementing IHBT. I think that would be welcome for some folks to hear from their peers, colleagues. So any advice you want to share with us?
I just want to state that I've really appreciated this conversation, Patrick, and it's great to be in the midst of colleagues, professionals like Georgeanne and Heather, and the important work their team does, and obviously Jeff and you, Patrick, are some of our big advocates. In terms of again advice, I would just say that again, it's been Belfair's experience that this service has a profound impact on the youth and the families in our community that Belfair serves. It feels as aligned with our mission as anything that we could be doing. And I would encourage anyone that has the sort of that has the appetite for it to go ahead and pursue it. It's not going to be easy, but that's sort of the nature of this entire thing. And I'd encourage any provider or organization that was seeking to develop one to stick with it and put in the hard work. And that, as I've already said, I think it starts with finding the right clinical leaders, finding people that understand this work to lead these teams. And I think from there, a lot of good stuff can happen.
Yeah, good.
Yeah, I agree with everything that Carl said. And I would add that if anybody is looking to start a team, please don't hesitate to reach out. I find people in this field and doing IHBT love to help others who want to do it.
Yeah.
It's not a competitive thing. Believe me, there's plenty of work for everybody and then some. So if you have any questions about it, or if you're thinking about it, or if you're implementing it and running into some roadblocks or things you're not sure how to tackle, please reach out to any of us. We'd love to, I'm saying we at CNA, I'm assuming that Carl and Heather feel the same, but I think we'd all love to help and to, help you with whatever individual questions or issues that you're having. I think we all get excited when we talk about IHBT with people who get it.
Yeah, yeah. And then you become kind of the cheerleaders, coaches for those folks. That peer support is really critical. And Heather, what about any advice?
Yeah, in addition to what Carl and Georgeanne said, I think it's important if an agency is considering beginning an IHBT program to just really understand the model that they're selecting. Use the model as your guide to set up your policies, your procedures. Make sure that you're not just educating your stakeholders one time. It needs to be continued re-education. Since the care management entities began, we've seen, and even we are a care management entity for Trumbull and Mahoning counties, and we've been blessed. We continue to grow. So that means more care coordinators are being hired on a monthly basis. Our other systems as well, staff come and go. So those staff at agency A might all be gone, and there might be new staff in place. So really making sure they understand what your program is, the families you can help, and show them the successes that you've had.
Yeah, I think that's a great point. That ongoing, here's how it's either changing or evolving, or here's our focus, or here's some of the things we want you to know, I think is really important. That's a really good point, as well as the other points here. Jeff, any final words of wisdom?
It's not a word of wisdom, but I just have to say, Patrick, I've been doing this for 35 plus years. This has just been such a pleasure to work with these providers and just problem solve and kind of figure out how we're going to get where we need and this ongoing dedication. And it's just refreshing to me from coming from a state agency to see so much support coming from a state agency really help the local communities build out a service. I mean, I had retired and I came back just to do this because I believe in it so much. And I really think this is one of the answers on keeping kids at home with their parents and for them to live in a happy, healthy environment.
Yeah, I agree.
Well said, Jeff, and the feeling's mutual.
Yeah.
Well, listen, thank you all so very much for sharing your thoughts, your experience, your wisdom. And I will say that when we post the additional information with the podcast, we're happy to include your email, if that's okay with you all, for the very purposes that Georgine identified. And we usually do also a kind of narrative summary of the podcast, some of the key points. So we'll be able to kind of tease out some some highlights, of which there are many for this. So I appreciate everybody's flexibility in organizing the time. I know that it's your jobs are demanding. We really, really, truly appreciate this, and I look forward to keep hearing the good news as we continue to implement and sustain these programs in our world for the kids and
Thank you.
families to hear about.
Thank you so
Thank
much.
you.
Oh, you're welcome. So we're gonna ease out. I'd ask you to stay on the Zoom just for a minute, but again, we'll consider this the wrap up. And thanks for folks for listening to this session of Innovative Conversations from the Child and Adolescent Behavioral Health Center of Excellence at Case Western Reserve University. So thank you.